Alrighty, well, we'll get started. This case is a 91-year-old female who has an appointment in a few weeks, but she noticed last night that a shadow came over her left eye, and when she closes her right eye, she can't see the bottom of her vision in her left eye, which is a new finding. She has a history of neovascular AMD with active CNV in the right eye, with a diagnosis of wet AMD in the right eye, been receiving Avastin since 7/7/15. Also has a history of neovascular AMD with active CNV in the left eye, also getting Avastin since 2014. Her medical history, she has hypertension, tremors of the vocal cord, pneumonia, basal cell removed from the right eyelid in 2017, has gotten the COVID vaccine, the flu vaccine and pneumococcal vaccine. Surgical history is negative. Systemic med, she's on propranolol, hydralazine, and amlodipine. Visual acuity is 20/32 -1 and 20/32 -2, and pressures are normal at 12 and 12.
Oh,
When was the last time she got her injection?
yeah.
I would have asked in, probably 2 weeks, 2 or 3 weeks.
Well, what about the vaccinations? How recently?
Oh, I don't know.
2020, 2022, and like 2017, it said. 2022.
Well, how recent is that relative to the presentation?
Oh, 2 years. This is a pretty fresh case.
Okay.
Okay, color fundus photo of the right eye. The media is clear, the nerve, the inferior looks sharp. It looks sharp, but there's some peripapillary atrophy, as well as some atrophy in the macula. There's a pigmented area, in the inferior macula, and then RP changes, scattered drusen, but appears flat.
Yep, I agree.
So left eye, some pretty symmetric appearing, media is clear, nerve looks sharp, borders, peripapillary atrophy, drusen scraps throughout the posterior bowl, some RP changes. I can't tell from here if it doesn't look like any like pre-retinal heme, but it does look like there might be some intraretinal. I can't really tell. There's definitely some RP changes, some in the macula, and then a punched out area of atrophy superiorly with some associated pigment.
Excellent. And it's kind of hard to see. I don't want to give it away, but if you look kind of, can you see where my pointer is? Right over here, where these vessels are, and then maybe right over here in these vessels.
I can't really see if there's
Okay.
is it a color change or it's more elevated?
It looks more like inside of the vessels, kind of almost like
Are those little plaques, like color plaques?
little plaques, I would
Okay,
say.
the superior one I can see
Yeah.
now, but the inferior one is hard for me to see.
This
But
one,
yeah, I can
kinda, if I zoom in, can you see it? Does that make it
Oh,
better?
yeah.
Is there also,
Zoomed in, I can see a couple of
is there also
little box cars.
retinal whitening?
Yeah, and the color, Dave was commenting on the retinal color. The color
Yeah.
change. What was her symptom? That was the eye with the symptoms, right?
Okay,
Yes,
so
the left eye.
yeah, so there may be some retinal whitening around those vessels that have that boxcar like appearance of some little plaques inside. Which would
It's hard to see. That's the thing is whenever we show
really hard.
problems in conference, we often show like a classic one. But this is more like a patient comes to your office, their retina looks all messed up
Yeah,
and they're complaining of a shadow, and it can be pretty subtle, their findings.
Yeah, so very good. I know those were kind of hard to see, but
thanks for zooming, that
Yeah.
was helpful. Okay, so right eye autofluorescence, it correlates well with the fundus photo. There's some areas of hypo autofluorescence, where we saw areas of atrophy before, some modeled areas of hyper autofluorescence in the superior macula, where there's been drusen and she has active wet AMD.
excellent.
And then in the left eye, similar appearing autofluorescence. She has some areas of hypoautofluorescence where there's areas of atrophy in the macula, and then that one atrophic area superiorly. And then modeled areas of hyperautofluorescence throughout the macula and surrounding those superior vessels as well.
Excellent.
So OCT of the right eye, the foveal contour looks a little bit disrupted. It's not quite as smooth, but it's still, you can still see the foveal contour. Your attention is drawn to the disruption of the outer retinal layers and with some drusen, and then maybe trace subretinal fluid, nasally, but it's just a little smudge of fluid. Otherwise, just maybe a couple, it's mostly outer retinal disruption.
So just that configuration is called the double layer sign right here. And just because I have my memory, so the double layer sign is a low-lying elevation of the RP, is the presence of a highly reflective layer and a further high reflective layer with Brooks membrane on its outer aspect. It's supposed to be irregular. So anyway, so that's considered a double layer sign, which is when you see the double layer sign, there are 41% of them have macular neovascularization.
All right,
So that's a double layer sign.
so also positive double layers.
Very good.
I find that more and more because Phil Rosenthal in Miami pushes the double layer sign. He's powerful in the world of retina, so. hear that
But it's,
term more
it's
and more.
good to look at when you have patients come in and they have AMD and not necessarily symptoms or fluid, and you can kind of see that. So sometimes you want to do an OCTA and it will show neovascular membrane. If they're not symptomatic and they're not actively leaking, I tend to watch them a little closely. I don't always treat those.
I have them for you. This is a vertical cut, I think, of the right eye, or the OCT, and yeah, pretty similar appearing, like disruption of the outer retinal layers, some scattered drusen, but no overt fluid. And then artifact and vessels.
Very good.
So OCT of the left eye, there's disruption kind of all layers here. There's disruptive foveal contour. And then your attention's drawn centrally to an area of like, it looks a little bit more elevated centrally actually, and then drusen. Yeah. But it just looks like more disruption of all layers in this one compared to just the outer layers in the other one, but
Dr. Cohn, would this be a CNV here?
Yeah, that's a fibrovascular pigmentosa attachment.
Yeah.
And then there's a macular neovascularization in that.
And then vertical slice of the left eye OCT, and you again see the drusen disruption of all layers, and then PED centrally, fibrovascular PED centrally, but no overt like internal fluid.
And then look at the retina architecture on the left and the right.
And then thickening on the, or atrophy nasally, and then some edema, or just thickening of the layers.
So that's superior, it's a vertical
Superior, yeah,
cut, so
superior.
left is inferior, right is
Okay.
superior.
So superior thickening of layers and some. A little bit atrophy, oh, okay, so that, does that go along with where the?
Yeah, where the
the
scotoma is.
Okay. Sounds good. So yeah, some thickening of the layers corresponding with the area of her symptoms.
Sure.
Surrounding the vessels there.
And there's not really fluid there, it's kind
Yeah,
of this
it's thick.
funny, it's this funny edema.
Yeah. All right, FA of the right eye, and we're seeing some, oh, I guess this is, I can't see how many seconds it is.
5 minutes, I think.
Oh, 5 minutes, okay. So this is a late FA of the right eye. You can see some hyperfluorescence around the nerve and all those scattered areas of atrophy, and then hypofluorescence in the macula, and a little area of hypofluorescence in bearded macula as well, but corresponding with the drusen and atrophy we saw on this photos.
Excellent.
Similar appearance later
2 minutes.
phase.
Might have put those in backwards.
Okay,
This is the other eye.
yeah. yeah, I don't think I have anything new.
No.
The right eye. Okay, so the left eye, an FA, we see this is at 24 seconds. So we're in the AV phase. It looks like there's some hypofluorescence in the macula itself, and also if you look at the vessel, some superior vessels, there's also some hypofluorescence where it almost looks like maybe some delayed filling compared to the inferior. All those vessels are pre-filled. Obviously some atrophy and like a mottled appearance in the macula from macular degeneration. And then, but superiorly, it looks like there's some delayed filling of
Which vessel?
the superior, like coming off the superior arcade
Yeah, I think it's an artery or vein.
artery.
It's an artery. It's weird that the vein is full.
Mhm,
Like you wonder where that's coming from.
yeah,
The artery's not filling.
yeah,
She must have an anastomosis somewhere.
yeah,
It's not as- Typically, you'd see non-filling of the artery and the.
right. So again, you're seeing non-filling along the area of where she's low,
Yeah, it's slow, but it's still.
Yeah. but it's taking its time because this is now,
Like I saw
There's
one
like
yesterday
20
where the whole area is filled.
yeah. So, and this is of course, the arteries are corresponding with where we saw the plaques earlier in the fundus photo.
Right.
What she's seeing. Say that again?
Yeah.
Oh, Karina said she
Yeah,
probably has
she's
some
some-
blood flow.
Yeah.
Yeah,
she's got
so it's
some,
like
so it's
this,
probably
like-
enough to
Yeah.
fill the vein there, but it's.
But it's slow and,
Yeah.
and especially compared to inferiorly, you can,
Yeah.
Yeah, because I had a patient yesterday with really no blood flow. Just
Okay.
like
More
nothing.
blocking.
okay, yeah. This one, it just looks like it's, very, very delayed and much slower to fill than the inferior vessels.
Mhm.
And FA, like later stage, so now did finally fill all the vessels, but of course we saw that it took a much longer time. But now it looks a little bit more symmetric, even though there's an area of, is that an area of non-perfusion, like superiorly, or is it more just
That's just a
the
spot.
atrophy? Yeah,
And then you see how the vessels start to light up later. It's probably either the slug, it's not washing out, or the vessel wall's a little damaged.
mm-hmm,
So the fluorescein washing out everywhere else,
mm-hmm,
but wherever the damage is, kind of stays a little hot for a while.
And that's kind of the area where we saw that like box carring and those little plaques earlier, right here.
Interesting, there was a decent plaque superior. The most visible
Yeah,
plaque was
the visible one.
superior, but that one doesn't seem to be a blocking one.
Yeah, that's
you
what
look at
I
the-
thought was interesting when I was looking at the FAs, and I kept going back to the fundus photo to here, and then that's kind of when I zoomed in and found that one area that looked like there were several kind of little plaques there.
Yeah, so similar appearing now, it looks like it's not, that the fluorescein is not leaving quite as fast, but it's just highlighting that one little vessel there, that where we saw the plaques earlier.
Mhm. Same thing, pretty much.
Yeah, although I guess now it does look like a little highlighted where that other plaque was severely in that.
And you can see that it's a broad area, the retina,
Uh-huh.
that whole area is
Yeah.
messed up. Super quadrant.
Yeah. Okay.
So, summary slide, oops, sorry.
Okay.
We had a 91-year-old female with a history of ARMD in both eyes who presented with a new inferior field vision loss in the left eye. The fundus photo of her right eye just showed some drusen, RPE changes, peripapillar atrophy, and a couple focal areas of atrophy. In the left eye, we also saw some drusen, the peripapillar atrophies, like a focal area of atrophy, and then a few areas of plaque visible and a couple of different arterials there. In the OCTs, they both showed some drusen. The right eye showed a small area of subretinal fluid, that double layer sign, possibly like a CNV, and then the drusen, CNV, and like a PED in that eye as well. Also the thickening on the one slide as well. And our FA of the left eye showed areas of decreased arterial filling in multiple areas of vessel bifurcation in the left eye. Any differentials?
Yeah, so I agree with you because you already flipped to the next slide. The highest differential with her symptoms is a VRAO, like with her decreased filling and like the whitening area around the vessels, and her saying she sees this one discrete area where it's not quite as obvious and it happened painlessly all of a sudden. goes along a lot more with BRAO. Obviously, she has underlying macular degeneration too, which can, if she had some atrophy in her superior macula, it might be causing some kind of inferior scotoma as well. But it sounds more in line with the BRAO, and then just with the history of hypertension, like other things on the differential could be like other vessel occlusions, like a BRVO, like a RAM, although it didn't really appear that way on her fundus photo. I didn't really see any RAM lesion. And then of course, just like hypertensive retinopathy. And then you can always include
Yeah.
radiation retinopathy.
And then just a couple other ones I included were like ischemic upset.
Confusion.
So just another ones I included, which I was just trying to throw things out there, like Susac syndrome, diabetic retinopathy, which didn't look like she was diabetic, just worsening the wet AMD, which you talked about, and then GCA, which unlikely, but she had a branched retinal artery occlusion. So branched retinal artery occlusions, the incidence is 5 per 100,000 people a year, and it accounts for 38% of all acute retinal artery obstructions. The obstruction leads to hypoperfusion of the retina, which then results in vision loss. And presenting visual acuity in patients with a BRAO is a useful indicator of their visual prognosis. In primate studies, they've shown irreversible damage can occur after 4 hours, but can also happen in as little as 90 minutes. And a BRAO can be divided into permanent and transient. The etiology of it is basically anything that can cause decreased perfusion of a retinal artery. Embolic causes are more likely. In 62% of cases, the emboli can be seen on fundus exam. Like in Our Lady here, we were able to see those plaques. And it's usually located at the bifurcation of a vessel, which again, in our patient, she had those areas at the vessel bifurcations. 98% involved the temporal retinal arteries, which in Our Lady, hers also did involve the temporal retinal arteries. The emboli can be cholesterol, platelet fibrin, calcified plaques from cardiac valves. You can have fat emboli from long bone fractures, also air from trauma or surgery, talc from IV drug use, and synthetic from any type of interventional procedures. And carotid artery plaques are the most common embolic source. And here's just another picture. I know Our Lady had a good one, but you can see here like a plaque here and then like a little bit of a plaque over there. Some non-embolic causes, you can have vasospasms like from migraines, cocaine, or sildenafil. You can also have inflammatory causes from like toxo, herpes, Lyme disease, GCA. Also Susac syndrome, which is a rare autoimmune condition. It's associated with encephalopathy, sensory neural hearing loss, and BRAOs. New studies have shown it involves like antibodies, anti-endothelial cell antibodies. And retrobulbar anesthesia can also cause BRAOs either from vasospasm, from trauma, compression, or from a reaction to the anesthesia. And it's been shown there's higher instances with preservatives. So if you do a retrobulbar with preservatives like methyl and propyl parahydroxybenzenate is more likely compared to preservative-free. Some risk factors for BRAO are hypertension, any type of carotid occlusive disease or atherosclerosis, coronary artery disease, hypercholesterolemia, smoking, age, so being elderly,
first floor.
diabetes, history of stroke.
MRI first floor.
And some less common risk factors can be like sickle cell, myeloproliferative disorders, antiphospholipid syndrome, and oral contraceptive pills. The pathology, so you get some histopathology changes after a BRAO. So acutely, you're going to get intraretinal edema, which is kind of what we saw in that OCT there. And then chronically, you'll get atrophy. And in some mouse models, 24 hours after a BRAO, you get the pyknotic nuclei, you get vacuolated spaces, you get degenerative changes in the ganglion cell layer and internuclear layers. Then at 21 days, you have retinal ganglion cells with nuclear loss. And just the pathophysiology is ischemia leads to apoptosis, which leads to loss of vision. So some signs and symptoms usually have sudden monocular painless vision loss, and a BRAO results in focal vision loss versus a central retinal artery occlusion. In visual acuity and permanent BRAO, 74% of patients will have a visual acuity of 20/40 or better, and in transient, 94% of patients will have a visual acuity of 24 or better, versus in a CRAO, 10.8% of patients will have a visual acuity of 20/40 or better, while 74% will have a visual acuity of count fingers or worse. Some signs
And
that
one thing that's comforting, when you tell the patients, typically their vision will improve for a while. So you can tell them this blind spot usually shrinks and the vision usually improves some over the first month or two, just because of the watershed area improves. So some people like to hear good news. It works.
And some signs you can have, so it's just some signs of retinal ischemia, like you can have some cotton wool spots or retinal whitening that follows the artery course, like we saw in that fundus photo. And kind of like I mentioned earlier, you can see retinal emboli in 62% of cases, which we also saw in our patient. And I know we had some retinal whitening, but here's also a really good picture. This is from like the Retina BCSD book, where you can see a pretty significant retinal whitening there. Diagnostic procedures, FAs are useful to assess perfusion of the retinal arteries and also help visualize the plaques within the vessels. You can see delayed filling and signs of retinal ischemia. In the OCT, you can identify retinal edema or atrophy. In the acute phase, you can see increased intraretinal reflectivity, intraretinal edema and thickening, which we saw, and chronically, you'll have intraretinal thinning. And visual fields are also useful, which can show peripheral or segmental loss of vision in the distribution of the artery. So these patients, 15 to 20% of patients with any type of acute retinal ischemia have a significant risk for stroke or already have evidence of stroke. So from the guidelines of the National Stroke Association, American Heart, and the AOA, they recommend referring patients with embolic retinal artery occlusions for urgent stroke evaluation. However, there was a study done, it was in 2017, that showed that only 18 to 35% of ophthalmologists actually refer these patients for acute care. The goal of this diagnostic procedures is to assess the risk for stroke, so doing like an MRA of the head and neck, an EKG, carotid ultrasound to look for any type of carotid stenosis, an echo to check for the heart valves and finding source of emboli, as well as blood pressure and cardiac monitoring. You can do ESR and SED rate to check for GCA. And in patients that are 50 years or younger, you might also include like specialized coagulation studies. And
The difficulty with referring, because the lady I had yesterday didn't want to go, is when you send them to most hospitals, they don't do all that.
Yeah.
Like here, do you guys, if someone comes in with a vision loss center, do they do the carotid? You do it all?
But they admit them usually.
Yeah.
You
they
admit
do
them,
that.
okay.
Yeah, here they do. We had a patient in clinic 2 weeks ago
Right.
who had a similar presentation. The week before she went to one of the admin and they just did a CT head and he said, no, there's no acute stroke, so.
Right, that's what I would do if I was an ER doc. So basically, most of it can be outpatient workup, so you look for acute stroke. So yeah, it's a tough,
I would never wanna go.
that recommendation is kind of weird. The lady yesterday, I was like, well, go to maybe Morton Plan will do it. I don't know.
TGH.
Yeah.
TGH here, we've seen enough of
Very
it. that we
serious.
have to
call
call
the
it.
PCP and try to get
Right,
that.
but most
Very-
people don't choose between
I know,
PCPs.
that's-
I mean, a lot of people don't have PCPs. All right, sorry to interrupt. Go
On the
ahead.
flip side, if.
No,
they're
I
having-
agree. It's always kind of mixed depending on who you ask, like what attending you ask, whether they're okay if they have like a good PCP, just kind of immediately going next day to the PCP and getting all these imaging outpatient, or just going over to the ED and kind of getting all this imaging. So it's mixed, at least at our program, depending on
Yeah,
who you
there's
ask.
some publications, some people are starting to write articles, like this recommendation is a little weird. And maybe not such a good idea, but currently it is the recommendation.
So management for these, usually aggressive management is not pursued. Some immediate treatment options, there's limited evidence without strong evidence for improvement of visions, but you can do like a YAG laser embolectomy, like IOP lowering medications, or like a para hyperventilation, hyperbaric oxygen. Thrombolytic therapy is something that can be used, but is controversial. And if the carotid stenosis is severe enough, you can do an endarterectomy if there's more than 70% occlusion. Dr. Cohen, have you ever tried any of these?
I do an anterior chamber tap usually to drop the pressure, just to try to move the envelope.
Uh-huh.
Do you guys, what do you guys do? What do you guys do where you are?
Usually nothing. We just kind of send them over to get the imaging.
Yeah, I do an ECT.
If it's fresh, if it's
If it's
reasonably
fresh, yeah.
Yeah.
If
I feel like every retina doctor has a good story how they were like visioning,
Yes.
doing a
I did-
fundus exam, saw a plaque, did a AC para, and then the plaque moved on.
Actually, when I first got to town, it was funny. When this conference started like 30 years ago, or it was before me, there'd usually be a bunch of retina people. They'd all bring their own cases. And so usually you'd have 5 different retina people. They'd show cases and the residents would talk about them. This was a long time ago. And when I got here, one of the other retina guys, who was also pretty new, showed a case with a central artery occlusion, showed a fluorescein of a perfused central artery occlusion, and then talked about how he did a tap and saved the person's vision. And I was thinking, like, the fluorescein you have showed that it was perfused, and so you didn't actually do anything, but I didn't want to burst his bubble. It was kind of funny to see the tap. But when I did the tap, I looked at her after, and my patient didn't benefit him. And the
They
yags.
feel like they're doing something.
Yes, yeah, that's right. All right, sorry, go ahead.
No worries. So complications that can occur are neovascularization due to retinal ischemia. In a review of 286 eyes compared to CRAO and BRAOs, 14.5% of CRAOs developed neovascularization, usually iris neovascularization and neovascular glaucoma in 83% of these eyes. Iris neovascularization only occurred in less than 1% of eyes in a BRAO. And if this does develop, you can do anti-VEGF or PRP for neovascular complications, which technically, I guess Our Lady, she's already getting VEGFs for her wet macular degeneration. So for prognosis, with time, kind of like Dr. Cohen talked about, the vessel can recanalize, but a lot of times the visual field defect can persist, although it's usually smaller. So in permanent BRAOs, 74% of patients that initially presented with a visual acuity of 20/40 or better, 89% of these patients will maintain the vision of 20/40 or better on follow-up. And transient, 94% that presented with the visual acuity of 24 or better, 100% of these patients retain a visual acuity of 20/40 or better on follow-up. And then just briefly about prevention, it's just controlling the factors that could lead to narrowing of blood vessels. So controlling the chronic conditions like hypertension, diabetes, smoking, and also maybe some medications for stroke prevention like statin, antiplatelet therapy, or thrombolytic prophylaxis. And here are some references.
Thank you. That was